So good afternoon. Good afternoon, Devin, and thank you for including me in this instruction course, which I promise is going to be very, very practically oriented. So intraocular pressure is where we usually start. So it's like having the smoking gun in your hand or a bloodied knife in your hand that incriminates you as the person who is the murderer. If you have high pressure, means you have glaucoma. So this is how we have been ingrained into thinking, and whether you're a glaucoma specialist, a normal general ophthalmologist, or even an optometrist, once you see a chart with a pressure which is about 21, if 25, glaucoma does sparkle in your head. So that is the time we have to know whether that pressure that you are looking at is accurate or not. And a lot of conferences you might have attended where they tell you now, intraocular pressure does not hold that important a status, but it is the most important causative risk factor for glaucoma. It is not a diagnostic parameter. You will not put the glaucoma label just based on intraocular pressure unless it is very, very high. But it is definitely the parameter which you are modifying. So the importance of intraocular pressure in your glaucoma chart is definitely primary importance. And it is the management target on which you are going to strategize on how to reduce your intraocular pressure and how to control this glaucoma. So the status of intraocular pressure is not anywhere gone down, only the status is to be looked at in a different way. But we know very well that intraocular pressure measurement, we call it, but it's only an estimation based on non-invasive techniques, which could be the Goldman, indentation using a Schiotz, an air puff tonometer, a dynamic contour tonometer, and so many new ones are coming up. So you may be using any one of these. But it is an estimation. It is not a measurement. You are not directly measuring the intraocular. That's the only way you can measure is to put in a probe into the eye to get the measurement. So in glaucoma management, as of 2019, 14th February today, we are using the Goldman applanation tonometer as the accepted standard amongst all other tonometers, none of which are completely reliable. We know that even the Goldman is not completely reliable, but it is a known devil. It is not a known Devi. Sorry, that's a spelling mistake, but it sounds very funny now. All studies which we look at and fall back on and target pressures which we are going to set are all in the literature based on Goldman. So if you are using Goldman, you know where you are going based not only on your own patient, but what the whole world studies done in good centers and vast amount of patients have to say about that kind of a scenario. That is why we continue to use the Goldman applanation tonometer as our baseline. As I said, the Goldman is well known to have known errors. Astigmatism compensation above 3 diopters of astigmatism is important. So if you have 3 diopters, take the reading in 2 axes. Corneal thickness, we have talked for at least 10-15 years. We have been talking about how thick corneas the Goldman overestimates. Very, very important is the large proptosed eye. You have myopic patients, you have patients who have eyes like these, which are not technically proptosed, but they're definitely prominent. And when you try to lift the eyelid of this patient, you are going to press your thumb on the eyeball. And when you take the measurement, you are going to artificially record a higher pressure. What do you say about a thyroid patient like that? You may not even hold, you will just hold the eyelids, but you will probably put little pressure. And he has huge muscles, which you can't see over here, but if you do an MRI or a CT, you can see it. And these muscles are pressing the eye from inside. So you are artificially going to get a high pressure. And you have patients on top who are squeezing. It happens all the time. So these are all the compounding factors where actually the patient pressure may not be that high, but you will artificially get a high reading. There are lesser known problems as well. Very common problem in my practice is patients on prostaglandins having huge eyelashes, one of which is growing a little bit down. You lift the eye, but that eyelashes comes right in the middle of your prism. And you are in a hurry and you don't see. That eyelash produces resistance, and I have actually seen how much pressure error occurs because of an eyelash being there in the prism between the cornea and the prism of your eye. Voluntary eye widening, you have bad uncooperative patients on one side and you have the over cooperative patients who will sit there with put their eyes as wide as they can and push their eyes in front sort of things, and that artificially causes high pressure. Habitual large quantity of water drinking and sometimes medically advised large quantity of water drinking. Most common scenario is the health checkup scenario, which in Mumbai is very, very popular. Patient comes in on an empty stomach, gives his blood, then drinks 1 liter of water, and then he has to wait for his bladder to get full for sonography. In that little half an hour, 45 minutes time, go and get your eye checked. And you record a pressure which is high. You record 25, 27, and there. So this is very common. Every day, I don't know how many patients in Mumbai are put through this. And I myself used to be a part of a health checkup scheme before. I tried to explain to them, never do this, but they never understood it. And you have Valsalva like breath holding. You have these people, who at every time they have to go in for anything, they hold their breath, they squeeze themselves, and sometimes the table is too close, they are fat, so they're taking in their stomach. You're doing all these kind of movements which actually is raising eye pressure, and you are nicely measuring over there and getting a high eye pressure. So you need to look at all that. So how do you go about ruling out all this? If you see high pressure without typical glaucoma changes, that is one of the red flags. And after ruling out all this, what do? You treat using the OHT guidelines, which has been from the OHTS. In absence of risk factors, you treat pressures about 25. In presence of risk factors like thin corneal, enlarged, you know all this. I am not going to go into this, but you have the OHTs also need to be treated if they have risk factors. But there is always a but, and I think Devan will very much agree with me. Before you start applying the OHTS factors, rule out angle closure before applying these OHTS risk guidelines, because you have people who are logging onto the internet, getting the star calculator, putting on all the risk factors, but haven't looked at the angle. This is the most serious error made every day in clinics, is not to look at the angle carefully. So before you apply OHTS, please rule out angle closure. Then you have the other extreme, where you have disc changes, field changes, but the pressures are well below 21 or quite a little below 21, and you don't know what is the cause. You can get artificially low readings with Goldman as well. In thin corneas, we know that very well. Sometimes it's a technical error. You have put too much stain, or your assistant has put too much stain, or there is already some stain on the prism head which you haven't wiped. So careless technique is one of the common causes. And the other one is the deep sunken eye. Again, you have patients whose eyeballs are way inside their orbits. You have to keep on moving in front to oppose, and sometimes your range of your slit lamp is gone, and your apposition is actually less than the area which you should, and you artificially record a lower pressure. So when you see a patient walking in with one of those eyes which I showed you in the picture, your mind has to be aware, I am going to probably artificially high record this patient, and when you see those guys with their eyeballs right inside, be careful, you might under record their pressures. Low pressures and glaucoma changes, you have a various differential diagnosis like neurological cases, disc anomalies, ocular ischemia, burnt out glaucoma, patients who had steroid responsive, uveitic, traumatic glaucomas, and old vein occlusions, which the discs still appear like glaucoma, the field changes appear like glaucoma, but these are not glaucoma. And of course, you have the classical NTG, which you have to diagnose after you rule out the other 4 things. So the important take-home message which I would like to give is that IOP is a known fluctuating parameter. So you always have to take many readings. Sometimes in the single visit, you may take 1 reading, send him for dilating or send him for perimetry, and come back and take another reading. Awareness of known sources of error, you have to be aware of those things which I told you and take the appropriate remedy. Diurnal variation is known, therefore we recommend in many cases to check the pressures at different times in the day, if not on the same day, maybe on a different day. And in some situations, after doing all this, you follow up the patient like a glaucoma patient, and over time you come to know of factors which were playing a role which didn't come to light in the beginning. So the basic thing about glaucoma management is, even when you are not sure, that one of the ladies here got up and asked that question, I'm not sure, just remember you don't have to take a decision today. A few 2-3 dots somewhere in the nasal field, sit quietly, keep on repeating perimetries, keep on doing the tests again. You have time to sit and think what's going on, but rule out angle closure first. Thank you very much.